Okay, welcome to our second fireside chat for PUBH 610. Today, we're very happy to welcome Dr. Jon Giftos, the Chief of Ambulatory Care at New York City Health and Hospitals Woodhull. So, as usual, I'll begin by introducing our speaker, sharing a little bit about Jon's background, and then we'll move into some questions. So previously, Dr. Giftos served as the Assistant Commissioner of the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene, where he led the city's strategic investments to reduce drug-related harms. Prior to his work in city government, Dr. Giftos served as the Medical Director for Addiction Medicine and Drug User Health at Project Renewal, a large housing and integrated health provider in New York City. In this role, he developed clinical services for people who use drugs in Project Renewal's crisis shelter, supportive housing, and affordable housing spaces. He also worked to expand harm reduction services while supervising care for people who use drugs in non-licensed spaces, supporting primary care doctors in their Article 28 clinics, and serving as medical director for Project Renewal's OASAS license program, which include medically supervised withdrawal, outpatient, and residential treatment. Prior to this, Dr. Giftos served as the clinical director of substance use treatment for the Division of Correctional Health Services at Rikers Island, where he oversaw diversion, harm reduction, treatment, and reentry services for incarcerated patients with substance use disorders. He was also the medical director of the Key Extended Entry Program, KEEP, the nation's oldest and largest jail-based OTP treatment program on Rikers Island. So, very impressive. Let's get started with some questions. So, reflecting on all of the experience that I just highlighted, can you pick an innovative effort, such as a policy, a program, a research project, or a partnership that you have had the opportunity to contribute to in recent years? And can you walk us through that experience of working on an innovation?
Thanks, Lili and Cezar. And it's nice to be with you guys today. Thinking back over the last few jobs that I've had, there's been a lot of moments, I think, where I've been able to work and partner with people to solve problems. But one of the proudest achievements for me was during my 3 years or so overseeing services for people who use drugs in the jail system, where we expanded access to treatment for people arriving to the jail system who were withdrawing from opioids and at high risk of overdose. So just to kind of like walk a little bit through that story, because I think it's a really interesting one. So in the United States, when people have an opioid use disorder, or they have a problematic relationship with opioids, and they are caught up in the criminal justice system and are detained in a jail, for the last 50 plus years, most correctional settings would not offer any treatment to people while they were incarcerated. They would often view their withdrawal syndrome in the correctional setting as a form of suffering that would kind of inspire them to change their life or change their use patterns or engage with treatment, et cetera. And the problem, so many correctional settings offered really no treatment for people. They allowed them to suffer. And they also allowed them to withdraw from opioids and lose their tolerance for opioids. And this was particularly problematic, not just because it caused suffering, but because people would return to the community often after jail with a much lower opioid tolerance than when they arrived. And if they picked up again or used again when they returned to the community, they were very, very high risk of overdose death. So not only was the sort of status quo across the country that you suffered unnecessarily when you were incarcerated, you also were put in a situation where you were at much higher risk of dying when you came out. So when I went to work in the jail system in 2016, I worked for the public hospital system, actually, that was providing care in the jail. And I think, interestingly, the New York City jail has had treatment for opioid use disorder in the jail since the 1980s. It was it's one of the few correctional settings in the country that actually provides methadone or buprenorphine treatment for people with opioid use disorder. And despite all the other risks and harms of incarceration in New York City, like that particular service existed there. But when I arrived and I started working with the team, I found out soon that they had a variety of non-clinical restrictions on people's access to those treatments. And the biggest one was that if you came into the jail system with a felony charge, and you were at risk of going into the state prison system, which was under a different leadership, they would not start you on any treatment for your opioid use disorder because they were afraid that you wouldn't be able to continue it if you were sentenced to go into state prison. So when we looked at the data, we found that we really were excluding thousands of people every year from potentially accessing treatment. So I partnered with the data team there, and we started looking at using data to understand this situation and to see if, in fact, we were making the right decision to deny access to treatment for people for this reason. When we looked at the data, we found out that the overwhelming majority of people who enter the jail system with a felony charge actually have their charge reduced or they are released on bail. And so even though they had a felony charge, many of them never went into the state prison system. And so when we found that out, we decided to collectively change our policy, and we moved away from a program that used these non-clinical factors to determine a medical treatment. And then we said we have universal access to treatment. Everybody that could benefit from it can access it. And then if for whatever reason you're going to move somewhere eventually where you can't continue it, we'll solve that problem when that time comes. So almost like a light switch, in like August or September of 2017, we switched our eligibility criteria, and we moved from about 24% of people accessing treatment to over 85% of people in the jail system with an opioid use disorder on treatment. What this then did was it reduced our in-custody overdose rates because everybody was on treatment, and it also reduced our post-release mortality. But it also changed the system's approach to caring for people who use drugs in the jail system and put their medical care and safety first and not secondary to other logistical factors that might be affecting them in the system. And it led to some rippling positive changes. An example of that was that for people that did need to transfer into state custody who were on treatment, we're putting pressure on the state to be able to receive them. And in the past, we had already taken people off of treatment, or they had not been offered treatment, so the state had no pressure to be able to receive people on methadone. Now that we had all of these patients on methadone, the state then needed to build capacity to receive them. And so really relatively quickly, the state stood up a program to be able to receive people on methadone. And so the kind of rippling effects of kind of doing the right thing were felt like across the system. And so it's one of my kind of proudest moments was really being in the right environment, using like kind of trying to put patients and health and safety first, organizing with a team to try to do the right thing and implement it at scale, and then seeing how that rippled across the system to drive further change was really rewarding to see. There's so many other factors I think that are important for the safety of people who are incarcerated or detained in criminal justice settings, but that was one of my, I think, kind of proudest moments.
That's an amazing story, an amazing success. Thank you for sharing. I feel like I have so many questions that I want to ask you after that. I'm reflecting on your work advocating for access to treatment and substance use care among some of the most underserved, marginalized groups, including people who are incarcerated. Can you, I guess, share a little bit about up and coming issues that you think as a field we need to be to have on our radar in terms of increasing and expanding access to care and support for people who use drugs who are maybe often forgotten by the system?
Yeah, it's a great question. I think that something that's been so I think the primary challenge right now in New York City and in many parts of the United States is that the drug supply is very volatile and unpredictable. And so people who may be using a substance thinking it's one thing find out it's actually something else, or it's a much higher concentration of something than they expected. And so that uncertainty and unpredictability in the supply, I think, is driving people's risk of dying. So overdose death in particular. And I don't think we have a good solution to that particular problem. We know that for people who have a substance use disorder, that are ready to try to make a change or to reduce their use or stop their use, we know we have services that can help people. But for many people, they're not quite in that space yet. They're not ready to necessarily stop using or change how they use. We don't have great tools to reduce their exposure to that uncertainty in the drug supply and to reduce their risk of death. And so I think things like drug checking services and then overdose prevention center services where people are able to use in more supervised environments to reduce their death risk is really important. But in terms of the treatment infrastructure and the way we provide services, I think we still have relatively high threshold services where people have to be able to commit to pretty substantial change in their life in order to access certain types of support. And I think we're working to try to lower barriers for people and to create a smoother on-ramp to services and supports so that people, wherever they are in a continuum of change, are able to access some additional support to improve their health and safety and move along a continuum of health, as opposed to have to make these really dramatic, huge changes, often under intense stress with high stakes, that when those don't pan out, people feel incredible shame and have huge setbacks. I think that culture of sort of huge waves up and down is slowly being replaced by a more supportive system that works with people over time, recognizing that a lot of these changes are hard to make and they require a sustained effort with more support than people currently get. So I think the system is moving in that direction, but it's not accustomed to it, and it's not without a lot of kicking and screaming in some parts of the system. And I think there's a lot of work still to be done.
Thank you, John. I appreciate that you highlighted the low barrier principle of the harm reduction approach, which is so important. I'll hand it over to Cezar for any follow-ups before I share another question from a student, actually, that I think is quite related to this.
I don't have any follow-up. I think you can go on to that student question.
Sounds great. So one student asked, having worked in various sectors of the healthcare system in New York City, what are your thoughts on the state of public-private partnerships to prevent overdoses in New York City right now?
That is a great question. So I think that, you know, the definition of a public-private partnership probably could be defined a little bit differently by different people. I think that public investment in things to reduce overdose risk is more significant than it was, but probably still much less than it needs to be. And so public funding for things like naloxone distribution, for example, is much greater in a place like New York City than it ever was before. And we do partner with lots of community organizations. And I say we as a former city government worker, but more as like a resident now of New York City. The city really partners with a lot of nonprofits and community organizations to distribute naloxone. And I think they do that quite effectively. And so I think that's an example, I think, of a public-private partnership that is, the city government alone cannot distribute the hundreds of thousands of kits that they currently are distributing through this network of partners. I think that a lot of state funding comes through the city to fund a lot of licensed treatment programs. And we're increasingly seeing Medicaid dollars being used more creatively to support social need and social support for people accessing certain types of medical care. I'm not an expert in this, so I'll just kind of nod to it, but the 1115 waiver that was, recently approved for New York State and prior Medicaid waivers allow state Medicaid dollars to be used to support, more non-traditional services that provide social support for people who have health issues. And I think we're seeing a movement in that direction where we invest in other parts of people's lives to improve their health and not just necessarily in reactive disease-oriented treatment. But there's still a lot of work to be done in leveraging those dollars to create, to build more supportive housing for people who need safe and supported housing, to enhance transportation for people that need to get to and from services, to provide recovery support. I think this is an area where places like New York City, where real estate is at such a premium, creating space for people to come together and be in community and support each other is not always easy. And I think that there's a fierce kind of battle for space. And I think we could do a lot better protecting space, people in recovery, as well as using our partnerships to support employment opportunities for people who use drugs, who are in various stages of recovery. All of these things stabilize people's lives, help them feel connected to community, and reduce risks indirectly of overdose. And I think that it's an all hands on deck kind of thing. But I think that the public does have to, our city and state government needs to partner with community organizations and businesses to do this work. And I would say there's a lot of, we're making some small strides, but there's a lot of work still to be done.
Thank you, John. I'll hand it over to Cezar.
So as you know, the title of the class that Lili and I are teaching is Public Health Leadership and Management. And we see you as a leader. That's why we've invited you to this talk with our students. So I'm going to ask these sets of questions, not to really pinpoint a particular place, but to really try and describe what can really be possible in a work environment to create, public health momentum and accomplishment. So you've worked at the jail setting at Rikers, at the city health department, and now at the city hospital, public hospital system. Which of these settings offered you the best opportunity to accomplish your goals and the most solid framework to be a successful leader?
It's a really good question. I think I could probably answer it in a diplomatic way that acknowledges sort of the strengths and of each of the places to support me as a leader, and also the delivery of, I think, quality service to support public health. I think in a way, as a physician, I think I have a sort of unique experience working in public health settings, because some public health settings, my clinical training brings a particular value and puts me in a space where I can demonstrate leadership simply by being a clinical leader and having clinical perspective. And so working in the public hospital system, I think either delivering healthcare in the jail setting or working at a community acute care hospital like Woodhull. I think being a physician, I've been able to offer a clinical perspective, but that clinical perspective has really been informed through my relationships and partnerships with communities and other, public health workers over the last 15 years. And it's that it's being in an environment like this that values not just my clinical training, but those experiences and perspectives that I bring into the room that I think is so important. And I think if I was working in a hospital setting where that was devalued, where all they cared about was my direct clinical perspective, but not what I've gathered from working in shelters and jails and alongside communities and harm reduction organizations and overdose prevention centers and outreach teams and all that stuff. I don't think that it would be as rewarding for me as a leader, or I don't think that that we would be as effective, because that perspective is so critical to delivering, good service. I think working at the health department, I had my clinical background was much less front and center. I think I was, it was an opportunity for me to really learn about other expertise in public health, epidemiologists, people who are great at operations, contracting and procurement, all the pieces that go into delivering good public health, support and services to New York City, but also just a really amazing bureau that had a real intentionality and thoughtfulness around how decisions are made, how perspectives are included in conversations, and that we're not kind of making decisions in a sort of limited, in a vacuum, or excluding different perspectives. And I think that taught me a lot about, leadership, and it held me accountable more than any other place to make sure that decisions were not made by one person with an MD after their name, but rather as part of a team that was intentional about including, the right perspectives, and that considered process just as much as everything else. And I learned a tremendous amount there. And so I think that although city government sometimes moves slower than any of us would like, I don't think that slowness is really because of intentionality. I think the slowness is because of contracting, delays and procurement delays and other things. But I think that intentionality was incredibly important, and I'll carry that with me, I think, through the rest of my career.
That's really great information that you're sharing. You touched on something that I'm curious about, and I think our students would be curious about. It's the idea of accountability. I'm wondering, do your goals change, as an individual when you're at different professional settings, or do they stay the same as a leader? And how do you hold yourself accountable to accomplishing your goals as a leader?
I think that, when you're in different jobs in different spaces, your role in moving things forward does change, right? And so in a place like the public hospital system, a lot of my decisions on a day-to-day basis are around how to care for particular patients, or how to, design or structure particular clinical interventions, or, I spend a lot of time recruiting and supporting leaders under me that are going to try to shape and cultivate, programming. And so there's a mentorship element to it. And so I have a particular role, I think, in this space, that with like a few different hats, and I think they're all really important. But my accountability to my direct reports and mentoring them, my accountability to my patients, I'm accountable to the community. I'm accountable to the hospital CEO. I'm accountable to our nursing leadership, who may need me to support the nursing kind of workforce in a certain way and advocate for and ensure that they're being treated fairly and respectfully. There's accountability, I think, for me that goes in a lot of different directions, and I think it's important to, it's important, I think, to acknowledge how much your decisions impact other people when you're in leadership, right? Like showing up to something matters a lot. Not showing up may signal a lot more than you think, right? And so I think you have to be really intentional about a lot of what you do, because nothing is really inadvertent. It's all kind of thought of as purposeful. And I think that was similar when I was at the health department in that leadership, environment as well. I mean, showing up to a meeting, showing up to a community group, joining a WebEx for something that someone's presenting somewhere else and showing support for them. I think showing up, is much more important when you're in leadership than people think. But I think listening too is really important in both jobs. You start to become an expert in something and think how everything works, and you can stop listening, right? And I think challenging yourself to just continue to listen for new information and what you don't know is really important. So I think that the nature of the jobs are different, but the focus on showing up and respect and listening, I think, are values that are important to me, and that I think have been really important in almost all the leadership jobs that I've had.
Thank you so much. Over to you, Lili.
Thank you, Cezar. I'm reflecting on, you talked about how you're a physician, you have an MD. Some students may be coming, from class, but also just in general in the field of public health, may be coming with a clinical degree of some sort. Others, are coming from occupational therapy or from nutrition, dietitians. Lots of different backgrounds come together in the field of public health. And I wonder, in your leadership positions, how your physician perspective affected your leadership decisions, or maybe the support or the buy-in you were able to gather. We do know that a clinical perspective is very valued, I think, in public health. And I wonder how that has maybe impacted your career in terms of leadership.
Yeah, it's a good question. I was actually talking about it just yesterday with somebody. We were talking about how when you're like in an executive job in meeting people for the first time or something, and you're a doctor, you're used to meeting patients for the first time, and you meet them a certain way, and you try to be warm, and you sort of sorry, my screen just disappeared. And you have a practice like engaging with people and asking questions, and if you apply that over to like just a person you're meeting professionally that's not a patient, sometimes you bring that same kind of energy and approach, and like it can be advantageous for you, right? Because you're like working on how to build relationships and trust quickly with people, like you have to do with patients. So we were just talking about like how some of the skills of clinical medicine, and bedside manner, et cetera, translate over into like other kinds of work. I also think you are, clinically, regardless of your profession, you're often working through this stepwise process of first collecting information, figuring out what you know and don't know, and then you have to sort of interpret it, and then you have to kind of think about what your plan is for next steps, et cetera. And I think a lot of different, clinicians have to refine that process. So I think it helps you organize your thinking and your data collection and your problem solving and your planning. So, there's also just your familiarity with how, healthcare works. And you forget that many people's experience with healthcare is as a patient, which is often very confusing, and you don't know how, systems work. You don't know, like who all the members of a healthcare team are. You don't know other things. And so being a healthcare worker who goes into public health, you bring all of that kind of familiarity with you. But you also bring biases sometimes, right? Because you may think that things are only done a certain way because you've seen them done in a particular healthcare setting, et cetera. And you have to really challenge yourself to be like, okay, that's what I've seen and what I know, but that's not the only way to deliver this set of services. And I found that to be actually often the case when I'm working in non-traditional clinical settings and someone comes who spent their whole career working in a hospital. They just can't imagine caring for somebody on the street, or they can't imagine going into someone's home and how could I care for them if I don't have my, otoscope that I can pull off the wall and look in their ear, and it's important, I think, to acknowledge that what you've seen as a healthcare worker may be a limited perspective as well, and you have to open your mind a little to learn about other ways of doing things. So I do think that it's just a lot of skills that you hone when you're working to build a healthcare profession that will add value to your ability to think about public health problems. But public health workers that have worked in non-traditional settings in the past or thought about things from a different perspective really can help you think differently and creatively about problems. And I think that, if you can find a way to merge those two things into your career, it's very rewarding, but everybody brings important perspective.
That was a fabulous response, very insightful, and I think will be very helpful to students from all areas, but maybe specifically those coming with a clinical perspective. Cesar, any follow-ups from you, or should I jump? Okay, so I'm going to move us along to our next section here. As part of this class, students will be developing an elevator pitch on a particular program or policy intervention that they're proposing to an assigned state government. And so we wanted to get your thoughts on elevator pitches. Can you share an example of a good elevator pitch that you received? Someone who shared an idea with you, an elevator pitch that made a difference for you in your career and led to some outcome.
Yeah. I think it's a really good skill to be able to explain something quickly and clearly. There's this story about, I think it was about like Woodrow Wilson or an old president from 100 years ago who was asked to give a speech, and he asked how much time he had, and he said, "Oh, how much time do I have?" And the person was like, "Well, you're the president. You could have as much time as you want. Why do you need to know?" And he said, "Well, if I have an hour, I could give the speech right now. If I have 30 minutes, I'll need a week. And if I have 5 minutes, I need a month." And I think it just, acknowledges that to say something short and succinct, like, takes a lot of thought and it takes a lot of planning, and you really have to be organized. I think for an effective elevator pitch, you need to start by making sure that your problem that you're solving for is very clear, right? And you need the person to buy in and believe that that problem is important and well understood before whatever suggestion or solution you're offering is going to matter to them, right? So don't skip over a very clear explanation of the problem that you're solving for. Once you feel like that's been really clearly presented, I think data, for example, and like really clear use of data can help to consolidate and reinforce the presentation of the problem, but not too much data, not too complicated, right? It should, if it's important enough, it should be simple, and you should be able to say it clearly and simply. And then I think you have to, you're convincing a person that what you're suggesting is going to solve for some problem. And hopefully it's the problem you just described. And being sure that you're focusing on how it solves that problem and not 25 other things, right? It may have a bunch of collateral benefits. It may have, all sorts of implications that you want to explain. But if you haven't clearly linked it to the problem that you just sold the person on as being important, then I don't think it's going to be effective. It's going to feel like a little bit theoretical, hypothetical, general, vague. If the last thing you said was some tangential benefit that doesn't seem that important, that's what they leave with, right? That may be the last word that's echoing in their ears, and they're like, yeah, that sounds interesting. But so keeping focused and making sure that what you describe is solving for the problem that you described, I think is really important. In terms of elevator pitches, when I was working at the health department, we had a lot of people, and there continue to be people who die alone of an overdose in their housing, and they have no one around who can intervene in the event of an overdose and deliver naloxone to reverse the overdose. And many people that die alone are actually living in technically in supportive housing environments where there's staff. And these staff theoretically could respond to an emergency, but how would that staff member know that you're experiencing an overdose, and how would they respond? And when I worked at Project Renewal during COVID, a lot of our patients moved into hotels, and they were alone in hotel rooms. And our staff were going around knocking on their door every half an hour to check on them to make sure that they were alive. And the problem with that is that 99% of the time they're annoyed that you're knocking on their door all day. And but if somebody is experiencing an overdose, it might have been 30 minutes since they last overdosed, and they might not be able to be resuscitated by the time you knock on that door. So it was a sort of disruptive to quality of life, and it was unlikely to really address overdoses. And so there was a company that reached out to us when we were at the city health department to pitch us a technology that would allow for a patient, before they use, to push a button on this device in their apartment that would set a timer, and at 5 minutes or whatever time they set it to, the timer would go off and it would start beeping. And if they couldn't shut it off themselves because they overdosed, it would alert the front desk that a health emergency had happened, and then a front desk worker could come to the apartment and respond. If they were alert and able to shut the alarm off, nobody was notified. And so this device was pitched to me as a potential solution to unobserved overdose in supportive housing. And the way they pitched it to me was very, very compelling and clear. And it was a technical solution to a very thorny, public health problem. They explained a lot of other benefits to it as well, but the elevator pitch was really, how do we reduce risk of overdose for people who are alone in supportive housing? And I thought they did a really wonderful job.
That's wonderful. What came of this?
It was, as far as I know, it was something that we were, exploring. I don't know the update on the status of it, but it was pretty compelling and cost effective and simple. The company also was founded by people who are in recovery, and so they had kind of a lot of thoughtful, just as an example of how people with lived experience bring a lot of unique perspective to really make sure that this was going to be effective. And they had provided, this wasn't part of the elevator pitch, this was more the expanded version, but they had anticipated, you want somebody to agree to put this thing in their apartment and use it. And so you have to address some trust issues and some questions they have around surveillance, and what happens if I push this button and the alarm goes off, but I shut it off myself. Does that alert the front desk to every time I've used drugs? And they had worked through a lot of those questions in advance to try to build trust that people would actually use this tool. And I think that their thoughtfulness in that was informed directly because of their own experience, direct experience.
That's an amazing example. And also you bring up the key part of planning for an elevator pitch, which is also anticipating questions and having, prepared responses. Great. That was such a great example. Cezar, to you.
All right. Last official question. We really believe that there are future leaders in public health in our section. So speaking to our students, what advice or messages would you have for them as they pursue public health as a career?
Well, I would say, first of all, so happy that so many of you are interested in working in public health and partnering with your community to help everyone lead happier and healthier lives. I know people are at various stages of their career, sometimes when they're in school, and so I don't want to make an assumption that everybody is 22 years old and doesn't already have a lot of experience. But for those that are earlier in your career, I would just say, don't overthink things. Like, the more experience you get, the more you will learn. And I think trying different types of work, sticking with it long enough to really understand it, being comfortable pivoting from one field to another. You're going to be collecting experience as you go. And that, I think, collection of experiences is what's going to enrich your perspective and help you be more effective as you kind of get deeper in your career. But your first move, I think a lot of people have a lot of anxiety over what that first move is. And I think many of us look back on our first move and it kind of feels a little random how we maybe started in one spot and ended up somewhere else. So to say just try different things and learn as you go, I think is really important. I also think it's important to both believe that you are going to accumulate a lot of knowledge and expertise, but you also always will have more to learn, right? And I think many of us, have a hard time with that balance. We either think we've built expertise and we're now the expert in the room, or we'll never know anything and that we don't add value because there's so much we don't know, and we have confidence issues and we don't use our voice and we don't practice speaking up and feeling like we can share a perspective even if we might be wrong. And so I think, acknowledging that sweet spot is hard to find in our careers, but whenever I think that there's a balance, as long as you're mindful and intentional of the balance and you want to try to both listen and speak up and practice using your voice, like that is really important. I think for if you never speak up, you'll miss opportunities, I think, to shape things and to be part of things. But if you also stop listening, you're going to really miss critical perspectives that I think will help you inform this work. And so doing both and always trying to just take stock of how much am I talking, how much am I listening, is important.
That's great. I think I love that you've hit on kind of coincidentally a lot of the themes that we've been trying to talk about each week in our class. So thank you for showing up for our students and for sharing your insights and experiences with them and us. We really appreciate you taking the time.
It was my pleasure.